And you know, what everybody's hot on now, aside from being able to use anti-angiogenic agents for gastric cancer, is immunotherapy, immunotherapy, immunotherapy. And I think you in Japan were the first to present randomized data on the use of nivolumab for gastric cancer. Can you tell us about ONO?
Yes. This is an Asian trial, including not only Japan, but also Korea and Taiwanese patients, and randomized patient 2-by-1 fashion to nivolumab and placebo arm. The subject is chemotherapy refractory, at least 2 or more previous chemotherapy, and actually overall survival was clearly improved with use of nivolumab. Difference in median survival time was 1.2 months, but the hazard ratio was 0.63, clear benefit. And 1-year survival rate was more than doubling. And also nivolumab is very well tolerated in this heavily pretreated patient population. So in Japan, nivolumab was approved in last September and included as a standard treatment, as a third line or later line treatment in Japanese guideline.
And so one difference between the Japanese guidelines and the US guidelines is PD-1 status. Can you tell us a little bit about why there's that difference there?
So actually in this Attraction 2 Asian trial, PD-1 status was evaluated, but the tumor tissue was only available from 40% of patients, and the PD-1 status was only evaluated in cancer cell, so not on immune cell. So as a result, PD-1 expression on tumor cells did not show any difference between positive patient and a negative status patient in terms of hazard ratio in overall survival, which was also included in Lancet paper. So as a result, nivolumab can be used regardless of any status of PD-1 in Japan. But I don't think this is a right story because this was based on the very small sample size biomarker analysis. Maybe we need more data from good tumor specimens as well as blood samples.
Yeah, so Yelena, I mean, what do you think? Do you think it's a PD-1 story? Do you think?
Well, you're looking at the pembrolizumab data and the positivity score, it's a moving target. And looking at the stroma and the surrounding tissue to the tumor is very important. So that's the distinction. While looking at, in CheckMate 32 or the Attraction 2, the positivity rate was only 30%. If you look at PD-1 expression by the combined positivity score of 1% or more, that's 70% of the patients. So you're really not excluding that many patients. Maybe it's logistically a little tricky to get the tissue and get the testing done before you can get your patients to pembrolizumab. But majority of the institutions are quite comfortable with PD-1 testing because of the lung cancer data. And so you just need to educate your pathologist saying that the bar for PD-1 positivity for gastric cancer is quite low. Please just, even if it's 1%, that's what we need to report. Whether or not PD-1 positivity is the biomarker, that's to be determined. Ideally, we find even a better biomarker, but it is important to narrow down the scope of patients that will receive this therapy to improve the benefit to the overall sort of population.
And so we've seen this data from Keynote, which is showing that if the earlier you treat, the earlier line of therapy that you treat with the pembrolizumab, potentially you do better. What are your thoughts on whether or not we might be moving the checkpoint inhibitors up to an earlier line? Is that the right thing to do?
And for MSI patients, absolutely. For EBV patients, probably. For unselected population, even patients with PD-1 expression, may not be. The truth is gastric cancer is an aggressive disease, and even in second-line therapy, patients present with peritoneal carcinomatosis, a lot of symptoms, and if you don't induce response quickly, you may lose some patients. And that's what the randomized study has shown that Kohei will be presenting at this meeting, is that in most patients, the chemotherapy is still going to be an important part of this puzzle. Mostly probably because, first of all, we're not enriching well enough, and secondly, because the time to respond for immune checkpoint inhibitors is not as brisk as with chemotherapy. So if you do respond, you tend to respond longer, and the survival curve has a tail on it. But if you don't respond quickly, you're in trouble. And Kohei, maybe you can give us a preview of what you're going to discuss.
Yes, this is a very important study based on their KEYNOTE-059 trial, which showed a better response in earlier lines of treatment with PD-1 positive. So KEYNOTE-061 trial was conducted to compare second-line paclitaxel and pembrolizumab for PD-1 positive tumor as a primary endpoint. The cutoff level is CPS 1, same as the FDA indication in third line. We did not use paclitaxel and ramucirumab because this trial was planned in 2014. At the time, paclitaxel and ramucirumab were not available in many countries. So as a result, this trial could not show the statistically significant prolongation of overall survival. Hazard ratio was 0.82 with a p-value of 0.042. A very borderline result because we did the interim analysis. And PFS was also included as a primary endpoint, so 0.04 is not sufficient to show a positive result. But very important point is the subgroup analysis. First, we also include the PD-1 negative patient population. So we can show the PD-1 negative patient population outcome. And also already abstract was shown that the PD-1 CPS 10, that means the more higher PD-1 expressor showed a more benefit. Hazard ratio was 0.64 in comparison with the paclitaxel. This is a very remarkable benefit. So it should be confirmed in additional study in first line.